here, and apologies to Dr. Emily Hardy for having to go last, but you're here, you made it. Today we're going to hear Dr. Emily Hardy talking about her CE topic on lipid management in ASCVD and looking at optimal targets. So without further ado, I will let Emily take it away.
All right, thank you. So we'll get started. I just want to mention that I don't have any financial or other disclosures that would impact the integrity of this presentation. And these are a list of the abbreviations that you'll see mentioned throughout the PowerPoint just for completeness sake. And we'll start by talking about our objectives. So the objectives of this presentation are to recall ASCVD or atherosclerotic cardiovascular disease pathophysiology and risk assessment, compare recommendations across dyslipidemia guidelines, describe the mechanism, tolerability, and effectiveness of various lipid-lowering drugs, review findings from various trials regarding LDL goals, and explain the utility of CAC scores for ASCVD risk stratification and guiding lipid-lowering therapy decisions. So before we get into the first objective, I just want to spend some time talking about why this is important. Lipid management, especially in the setting of ASCVD, is probably something that we've heard a lot about. Over time, lipid management, especially in these patients, has continued to change, and this includes changing LDL goals and different treatment strategies, such as targeting a specific LDL or a specific percent reduction in LDL. However, there has been emerging evidence that has shown that use of LDL targets alone may not provide sufficient cardiovascular risk reduction. So with this, we'll likely start to see changes to guidelines and movement towards treating based on ASCVD risk rather than specific LDL goals. So our first objective, we'll talk about ASCVD pathophysiology and risk assessment. So just as a reminder, lipoproteins contain cholesterol, triglycerides, phospholipid, and protein, and lipids are attached to circulating lipoproteins to allow for transport and solubility within the body. So first we have HDL or high-density lipoprotein. This is commonly referred to as our good cholesterol and helps to transport circulating cholesterol to the liver so that it can be excreted. Then we have LDL or low-density lipoprotein. This is commonly referred to as the bad cholesterol, which high levels of this are associated with plaque formation that may lead to an increased risk of ASCVD or cardiovascular disease. Then we have our VLDL or very low-density lipoprotein and chylomicrons. Both of these are responsible for carrying triglycerides through the body. Chylomicrons carry triglycerides that are dietary, whereas VLDL carries triglycerides that are endogenous from the liver. Two of the lipoproteins that have increasing research lately are apolipoprotein B or ApoB and lipoprotein A. So apolipoprotein B is a critical structural protein that's found in chylomicrons, LDL, VLDL, and lipoprotein A. So as we'll talk about, atherosclerosis involves apolipoprotein B containing lipoproteins. So even if someone has the low LDL, their overall lipid profile may be pro-atherogenic, leading to an increased cardiovascular risk. Then we have lipoprotein A, which is similar to LDL, and it contains an LDL-like particle, apolipoprotein B, that is bound to apolipoprotein A. So notably, this has been an increasing interest lately, and it's found to be an independent risk factor for ASCVD. Differently from other lipoproteins, this is mainly genetically inherited and is not affected by lifestyle changes. So ASCVD is the leading cause of morbidity and mortality globally. Clinical ASCVD is defined as acute coronary syndrome, history of MI, stable or unstable angina, coronary or other revascularization, stroke, TIA, or peripheral artery disease, all due to an atherosclerotic cause. So in summary, atherosclerosis has accumulation of lipids and various fibrous elements that lead to formation of a plaque. On the right, this is just a visual representation of a plaque in an artery. Formation of the plaque leads to narrowing of the arteries and ultimately decreased blood flow, which may lead to complications such as the conditions that comprise clinical ASCVD. Patients with atherosclerosis are often asymptomatic, but they may have shortness of breath, dizziness, or chest pain, especially during a more acute event. So if we look at the pathophysiology in a little bit more detail, the process starts with some kind of endothelial dysfunction or damage that can be due to things like hypercholesterolemia, hypertension, smoking, or hyperglycemia. These damaged endothelial cells express molecules that attract white blood cells and allow them to move into the vascular wall and start oxidizing LDL. So these oxidized LDL molecules then attract even more white blood cells, and this leads to further accumulations and promotion of a pro-inflammatory state. So as you can see, there's kind of a positive feedback loop here happening. Foam cells are eventually formed as macrophages start to uptake the oxidized LDL, and they're eventually engulfed by other white blood cells and smooth muscle cells. So this process of accumulation leads to the production of a lipid core and formation of a fibrous plaque. This plaque eventually ends up covered in endothelial cells and starts to attract calcium, which crystallizes or hardens and forms the plaque that we associate with atherosclerosis. If the covering endothelial cells become compromised, areas of the plaque can rupture and allow it to stick out in the artery and lead to clot or thrombus formation. So next we'll talk about some of the risk estimators used for ASCVD. But just as a reminder, before we do that, when we talk about primary prevention, we're talking about patients who are at high risk for ASCVD and preventing an event before it occurs, whereas secondary prevention, we're talking about patients with ASCVD, and this is done to reduce the rate of recurrence. So this is the ASCVD Risk Estimator Plus from 2019 that was released by the American Heart Association and the American College of Cardiology. Some common things that most of these risk calculators will be age, sex, history of diabetes, and tobacco use, among some other things. When compared to the 2013 risk calculator, this one also accounts for whether a patient is on a statin, aspirin, their LDL, and their diastolic blood pressure. One of the newer calculators that was published at the end of 2023 is called the AHA Prevent Calculator. This was developed from a large observational study and may be used to calculate risk of ASCVD, cardiovascular disease, or heart failure. Uniquely, this calculator also includes eGFR, A1C, and zip code is used as a surrogate marker for socioeconomic status. Notably, this calculator does not include LDL, diastolic blood pressure, or race. So for our first knowledge assessment, which of the following is not accounted for when considering a patient's ASCVD risk? A, LDL, B, blood pressure, C, ideal body weight, or D, history of diabetes? Yeah, C, ideal body weight. So our next objective is to compare recommendations across different dyslipidemia guidelines. So before we do that, we'll talk a little bit about risk-enhancing factors, which were mentioned in the primary prevention guidelines. So these are comorbidities that were expanded in 2018 guidelines a lot and are essentially saying that anyone with these comorbidities are at a higher risk of ASCVD. So this is thought to provide a more individualized and comprehensive approach to cardiovascular disease risk assessment. So these include family history of premature ASCVD, primary hypercholesterolemia, metabolic syndrome, CKD, chronic inflammatory conditions, premature menopause or history of preeclampsia, high-risk race or ethnicity such as South Asian, persistently elevated primary hypertriglyceridemia, and then something that was expanded a lot on in the most recent guidelines were, if they're available, an elevated high sensitivity CRP, an elevated lipoprotein A, an elevated apolipoprotein B, or an ankle brachial index below a certain threshold. Very high risk is also a term that is mentioned in the 2019 guidelines. So this is for patients that need secondary prevention. This should be used to help assess these patients when directing their statin management and other lipid-lowering therapies. So very high-risk patients have either a history of multiple major ASCVD events or one major and multiple high-risk comorbidities. So I've listed the major events and high-risk conditions here just for completeness sake. So when we talk about the ACC and AHA guidelines, for primary prevention, we want to make sure that we're calculating the ASCVD risk using some of these calculators that I discussed earlier. In most patients with an LDL of 70 or higher, or with comorbid diabetes, you're going to want to use at least a moderate intensity statin. And in patients who have an LDL of 190 or higher, you're going to want to use a high intensity statin. These guidelines heavily rely on the use of risk-benefit discussions with patients, especially if they fall into a more borderline risk category. Secondary prevention guidelines, kind of like I just mentioned, we want to classify if someone is at very high risk. Typically for secondary prevention, a high intensity statin is going to be recommended, and you're going to want to target an LDL reduction of at least 50% from baseline. Guidelines can recommend considering addition of adjunctive therapy if the LDL remains above 70. So this could be ezetimibe or a PCSK9 inhibitor based on the desired LDL lowering that still needs to occur. So then if we look at the 2025 AACE guidelines, these guidelines really focused on patients who are receiving standard of care, such as patients who are already on maximally tolerated statins and still not at their respective LDL goal. So the major points from this guideline include targeting an LDL of less than 70, which notably the prior guidelines from 2017 recommended an LDL of less than 55. Additionally, we'll talk about some of the medications later in this presentation, but this guideline found insufficient evidence regarding the use of inclisiran. Then lastly, we have the 2025 ADA guidelines. These focus specifically on cardiovascular risk management in patients with diabetes. For primary prevention, similar to other guidelines, they recommend an LDL of less than 70, but for secondary prevention, notably, they use an LDL target of less than 55. They also recommend the use of PCSK9 inhibitors, bempedoic acid, or inclisiran in patients who cannot tolerate a statin. So next we'll kind of talk about how the guidelines have changed over time. The ASCVD lipid management guidelines have changed a lot more than some of our other guidelines. So in the early 2000s, the National Cholesterol Education Program, or NCEP, released cholesterol guidelines that suggested using specific LDL targets. At the time, there was emerging evidence that had started to suggest that LDL-lowering drugs, primarily at this time statins, reduce the risk for major coronary events and coronary death. These guidelines defined an optimal LDL as less than 100, which is higher than most of the LDL targets that you'll see mentioned in the literature today. Other available lipid-lowering therapy at this time included bile acid sequestrants and fibric acids. In 2013, the American College of Cardiology and American Heart Association released a new set of guidelines that provided the first real update to lipid management since the early 2000s. One of the biggest changes to this guideline was the removal of specific LDL targets, so not targeting either a specific LDL or even a percentage reduction in someone's LDL. And these guidelines recommended using these measures only to assess adherence and response to therapy. Additionally, the guideline recommended the use of maximally tolerated statins for all patients who are thought to benefit, such as patients in high-risk categories. At the time of this guideline update, trials typically used fixed doses of statins, and if the doses were titrated, it was to get to high-intensity statins, not to titrate based on a specific LDL goal. So the expert panel did not feel that there was sufficient evidence to recommend using an LDL target. In 2018, the American College of Cardiology and American Heart Association released another guideline update. So one of the most significant changes in this guideline update was reinstitution of LDL goals and recommendations regarding the use of adjunct therapies for additional LDL lowering. So notably, the LDL goal suggested for most patients, as we just discussed, was less than 70, and this represented a shift towards more strict LDL lowering. Additionally, these guidelines discuss the use of additional lipoprotein markers and consideration of CAC scores when you're assessing a patient's ASCVD risk. And then since 2018, use of even stricter LDL targets has been suggested, especially for patients who are at an increased risk of ASCVD. So for example, the European Society of Cardiology just released a guideline in 2024 that recommended using an LDL of less than 55 in patients at very high risk and less than 40 in patients with a history of multiple ASCVD events. So why have the guidelines for ASCVD and lipid management changed so much? Um, Statins alone are not sufficient to reduce LDL and cardiovascular risk in most patients. Initially, there were a lot of questions about whether the reduced cardiovascular risk seen in patients on statins was due to the statins themselves or the LDL reduction that occurs as a result. So, as a result, this is when the 2013 guidelines um, came out, and patients were always on a high intensity statin with no LDL goal. But at this time, we were still seeing a lot of ASCVD events, even when people were on the maximally tolerated statins, and we were not targeting lower LDL goals. So, more recent research has consistently shown that lower LDL levels are linked to a reduced ASCVD risk, which has helped to shift practice towards targeting a more aggressive LDL target. We've also had a lot of advances in our lipid-lowering medications that have allowed us to achieve lower LDLs than we have been able to previously. And then more recently, research has suggested that using LDL alone as a target may not capture the full picture of someone's cardiovascular risk. So residual risk reduction is a term that you'll see a lot now, and this involves addressing the remaining factors that can contribute to cardiovascular events. And it's suggested that more intensive lipid-lowering therapy may result in benefits with other lipoproteins than if you're targeting a more moderate LDL. So moving on to our knowledge assessment 2, based on the various guidelines, what is the most common LDL goal for patients with or at risk for ASCVD? A, less than 55, B, less than 70, C, less than 100, or D, less than 190. B, less than 70. So less than 70 is commonly used as our target, but in the coming years, we might start to see a shift toward more strict LDL goals, such as less than 55. So moving on to our next objective, we'll talk about the mechanism, tolerability, and effectiveness of the various lipid-lowering therapies that are outlined in the guidelines. So just as a quick reminder, cholesterol synthesis primarily occurs in the liver, and it includes the conversion of acetyl-CoA to HMG-CoA. HMG-CoA is then converted into mevalonate via HMG-CoA reductase, which serves as the rate-limiting step of cholesterol synthesis. Mevalonate is then converted through multiple steps finally into cholesterol. So this is just a visual representation of the cholesterol pathway and the different sites of action that the drugs that we'll be talking about act on. So when we talk about statins, I'm sure this is a class of drug we're all pretty familiar with. So these are reversible HMG-CoA reductase inhibitors. They're responsible for preventing the conversion of HMG-CoA to mevalonate during cholesterol synthesis. This results in a decreased amount of cholesterol synthesis and also LDL receptor upregulation and an increased uptake of LDL. Statins are well known for their pleiotropic effects, such as anti-inflammatory, antioxidant, and immunomodulatory benefits. And this is why originally there was some thought that statins provided the benefit rather than LDL lowering itself. They're typically well tolerated, but the most common side effects that we think about are myopathy and hepatotoxicity. And just as a reminder, statins are classified based on the amount of LDL intensity lowering that they provide. So low intensity statins provide less than 30% LDL lowering, whereas moderate intensity statins provide a 30 to 49% LDL lowering, and high intensity statins with at least a 50% LDL lowering. The next drug that we'll talk about is ezetimibe. So this inhibits cholesterol absorption at the brush border of the small intestine via NPC1L1. This results in a decreased hepatic delivery and stores of LDL and an increased clearance of cholesterol. The typical dose for this is 10 milligrams daily, and it's been suggested to lower LDL about 15 to 20%. It's generally well tolerated, but some side effects that can be concerning are hepatotoxicity and myopathy, but typically not as severe as we think about with statins. The next drug that we'll talk about is bempedoic acid. So bempedoic acid inhibits adenosine triphosphate citrate lyase, or ACL, which is an enzyme involved in cholesterol synthesis. This results in a decreased amount of cholesterol synthesis and upregulation of LDL receptors. The typical dosing is 180 milligrams daily, and they have been suggested to lower LDL about 17 to 28%. Some of the more concerning adverse effects that we think about are hyperuricemia and tendon rupture. Other than these, it is typically well tolerated, but it may elevate LFTs or serum creatinine. Next, we'll spend some time talking about PCSK9 inhibitors, which is one of our newer classes of drugs. So we have alirocumab or Praluent and evolocumab or Repatha. So these inhibit PCSK9 from binding to our LDL receptors. So normally PCSK9 binds to LDL receptors and results in degradation of these receptors within the liver. So by inhibiting PCSK9, there's an increased amount of LDL receptors, and this helps to improve clearance of LDL. Both of these drugs are subcutaneous injections and can be given either every 2 weeks or once a month. Notably, PCSK9 inhibitors are monoclonal antibodies and have been suggested to reduce LDL about 45 to 60%, which is a pretty significant LDL lowering when we compare it to some of our other available agents. The most common side effect with this is localized injection site reactions. PCSK9 inhibitors can be used as monotherapy, but due to the studies that got them approved, they're typically recommended as an adjunct therapy. And then the last drug that we'll talk about is inclisiran. So this is one of the newer LDL lowering therapies. This is the first small interfering RNA or siRNA drug that has been approved for lipid lowering. So this drug has a mechanism similar to PCSK9 inhibitors and acts on the same pathway, but it works a little differently by leading to a decreased production of PCSK9. So this binds to the RNA-induced silencing complex in the liver, which then is able to bind to mRNA that encodes for PCSK9 production and cleave that mRNA. This drug should not be used in combination with PCSK9 inhibitors due to acting on the same pathway. This has been found to reduce LDL about 50%, but something unique about this drug is that it has a longer-term lipid-lowering effect, so a single dose of this has been suggested to have a maintained effect for up to 6 months. So similarly to the PCSK9 inhibitors, this is also a subcutaneous injection, and side effects include injection site reactions and possible antibody development. There is a potential risk of increased type 2 diabetes with this drug, but the mechanism of the association is not yet clear or known, and this is an area of evolving research currently. So which of the following drugs works by inhibiting cholesterol absorption via binding to NPC1L1? A, statins, B, ezetimibe, C, bempedoic acid, or D, cholestyramine? B, ezetimibe. Okay, so moving on to our next objective, we're going to review findings from various trials regarding LDL goals specifically. So the first trial that we're going to talk about is probably one you guys are all a little familiar with, the Improve It trial. So this looked at ezetimibe added to statin therapy after an acute coronary syndrome. So kind of like I mentioned earlier, at the time of this trial, it wasn't known if the addition of other lipid-lowering therapies to a statin would reduce the rate of cardiovascular events further. So the purpose of this study was to determine if the addition of ezetimibe would further reduce this risk. This trial was a double-blinded randomized control trial that compared simvastatin 40 milligram monotherapy to simvastatin plus ezetimibe. This study looked at 18,000 patients approximately, with around 9,000 in each group. Included patients had to be at least 50 years old and hospitalized in the past 10 days for an acute coronary syndrome, which they defined as an acute MI or someone who was hospitalized for high-risk unstable angina. Patients also had to have an LDL of at least 50 at baseline, and the maximum LDL at baseline was 100 if they were on lipid-lowering therapy and 125 if they were not on lipid-lowering therapy. Notably, the drug or the statin that they used in this was simvastatin 40 milligrams, which is equivalent to a moderate intensity statin. The baseline characteristics of this trial were similar between groups, and there was a mean LDL of about 94 in each group, and about 34% in each group was on a statin prior to randomization. The primary outcome looked at a composite of cardiovascular death, major coronary event, or non-fatal stroke. So when we look at the results of this trial, the median average LDL was found to be about 53.7 in the study group versus 69.5 in the simvastatin monotherapy group, and this was statistically significant with a p-value of less than 0.001. So this represented a 24% further lowering of LDL when combined with ezetimibe versus simvastatin alone. The primary outcome occurred in 32.7% of the study group versus 34.7% in the monotherapy group with a hazard ratio of 0.94. So the primary outcome was significantly reduced in the combination group when compared to the monotherapy group alone, with a number needed to treat of 50. This was the first trial to show that the addition of a non-statin lipid-lowering therapy with a statin improves cardiovascular outcomes in addition to improving lipid lowering, and helped to prove the LDL hypothesis, which is that LDL lowering is responsible for the reduced cardiovascular risk rather than statins themselves. So notably, this trial also helped to form the basis for an LDL goal of less than 55 in the 2017 AACE guidelines. The next trial that we'll talk about is looking at the long-term safety and efficacy of achieving very low levels of LDL cholesterol. So this was actually a pre-specified analysis of the Improve It trial that we just discussed. So the purpose of this trial was to assess the safety and efficacy of achieving very low LDL levels at 1 month. In this study, very low LDL levels were defined as an LDL of less than 30. So this analysis included about 15,000 patients from the Improve It trial, and these were patients who had not experienced either a primary efficacy event or a pre-specified safety event at 1 month of the Improve It trial. Patients were divided into 4 groups based on their LDL at 1 month, which you can see listed here. So notably, about 6.4% of patients achieved an LDL of less than 30, with the median LDL in this group being 25 at 1 month, which is a lot lower than the LDLs that you'll see recommended in literature. And this analysis examined the same primary efficacy endpoint from the Improve It trial, as well as a variety of safety outcomes, such as adverse muscle events, elevated AST and ALT, neurocognitive events, hemorrhagic stroke, hospitalization for heart failure, and non-cardiovascular death. So as you can see, these are the results of the trial split up by each LDL subgroup. So as a reminder, the primary efficacy endpoint listed here was the composite of cardiovascular death, major coronary event, or non-fatal stroke. As you can see, the primary endpoint was significantly reduced among patients with LDL levels that were progressively below 70, with the lowest risk being present in the group that had an LDL of less than 30. Additionally, there was no significant association between LDL level and any of the pre-specified safety events. The next trial that we'll talk about is the 4-year trial, and this looked at evolocumab and clinical outcomes in patients with cardiovascular disease. So the purpose of this study was to determine if the addition of a PCSK9 inhibitor, such as evolocumab, to a moderate or high-intensity statin would reduce major cardiovascular events in patients who had an LDL greater than 70 and clinical ASCVD. So this was a randomized, double-blinded, placebo-controlled trial that compared evolocumab at either its every 2-week or monthly dosing to placebo. The study included about 27,000 patients with around 14,000 patients in each group. Included patients were 40 to 85 years old with clinical ASCVD and either 1 major or 2 minor risk factors. Major risk factors included things like tobacco use and diabetes, whereas minor risk factors included residual coronary artery disease with stenosis, non-MI related revascularization, or metabolic syndrome. All patients had to be on at least a moderate intensity statin and had to have an LDL of at least 70 to be randomized. The primary outcome was a composite of major cardiovascular events. So this included cardiovascular death, MI, stroke, hospitalization for unstable angina, or coronary revascularization. When we look at the results of this trial, the primary outcome occurred in 9.8% of the evolocumab group versus 11.3% in the placebo group, with a hazard ratio of 0.85 and a p-value of less than 0.001. And this represented a statistically significant 15% relative risk reduction. This risk reduction was driven primarily by non-fatal MI, stroke, and reduction in revascularization. The number needed to treat was 74 for this. There was no significant difference in any of the adverse events, including neurocognitive effects, but there was a slight increase in injection site reactions with the evolocumab group. When we look at the LDL data specifically, the baseline LDL was 92 for both groups. In the evolocumab group, the LDL was reduced by 59% at 48 weeks to a median LDL of 30, which was statistically significant. So in conclusion for this study, the addition of a PCSK9 inhibitor to a statin lowered the risk of cardiovascular events, and this study also suggested that the use of an LDL goal below current targets may be beneficial and well tolerated. The next trial that we'll talk about is the Ebbinghaus trial. This looked at cognitive function in a randomized trial of evolocumab. So the purpose of this trial was to examine if the use of evolocumab had any adverse impact on cognitive function, especially when LDL was reduced to very low levels. This was a randomized, double-blinded, placebo-controlled trial that prospectively analyzed cognitive function in a subset of patients from the 4-year trial that we just discussed. This analysis included about 1,200 patients with about 600 patients in each group. Cognitive function was assessed using the CANTAB score and various elements of that score. The primary outcome specifically looked at the Spatial Working Memory Strategy Index and was a way to assess someone's executive function, while the secondary outcome looked at other points of the CANTAB score, including someone's working memory. When we look at the primary endpoint that was assessing executive function, the evolocumab group was found to be non-inferior when compared to placebo. There were no significant differences found in any of the secondary outcome score components. When we look at the LDL results specifically, patients were stratified according to their lowest attained LDL score. This included about 661 patients in the evolocumab group that attained an LDL of less than 25, which is what they defined as a very low LDL level. No association was found between any cognitive adverse effects and the use of evolocumab, including patients who attain these very low levels of less than 25. So in conclusion, evolocumab was not associated with cognitive decline in these patients, including patients who achieved this very low level of less than 25. The last trial that we'll talk about will be the Odyssey Outcomes trial. So this looked at alirocumab and cardiovascular outcomes after an acute coronary syndrome. So this was a multi-center randomized double-blinded trial that compared alirocumab every 2 weeks to placebo. Notably, when we look at the dosing of alirocumab in this trial, the dose was titrated to keep an LDL between 25 and 50, which is a lot lower than what we'll see mentioned in some of the guidelines currently. This trial included around 19,000 patients with 9,462 in each group. Included patients were at least 40 years old with a recent acute coronary syndrome in the last 1 to 12 months and inadequate lipid control, which was similarly defined to the 4-year trial that we discussed earlier. The primary outcome was a composite outcome of death from coronary heart disease, non-fatal MI, fatal or non-fatal ischemic stroke, or unstable angina requiring hospitalization. The primary outcome occurred in 9.5% of the alirocumab group versus 11.1% in the placebo group. And this translated to a 15% relative risk reduction and a number needed to treat of 63. Additionally, similar to the 4-year trial, there were no significant safety events other than a slight increase in local injection site reactions in the study group. When we look at the LDL data specifically, the baseline LDL was around 87, and the investigators compared the incidence of the primary outcome between the different baseline LDL groups and reported that the greatest absolute reduction occurred in patients who had a baseline LDL of at least 100. So they had a 3.4% reduction in their primary composite endpoint. So in conclusion, this trial demonstrated that the addition of PCSK9s lowered the risk of composite primary outcome in these patients with a recent ACS and inadequate lipid control. Additionally, when this is combined with the results of the 4-year trial that we discussed earlier, this further raises questions about what the true optimal LDL target really is. So moving on to our next knowledge assessment, based on the primary literature reviews, which of the following is true regarding LDL targets? A, LDL less than 25 is associated with neurocognitive adverse effects. B, there's no suggested benefit to lowering LDL beyond the current recommended goal. C, pleiotropic effects of statins were responsible for the improved cardiovascular outcomes in the IMPROVE-IT trial. Or D, the ideal lower bound of LDL is an evolving area of research and yet to be determined. Yes, D. So now we'll move on to our last objective, which is to talk about the utility of CAC scores for ASCVD risk stratification and guiding lipid-lowering therapy decisions. So what is CAC? This is our coronary artery calcium that occurs due to the progression of atherosclerotic plaques. At later stages, this coronary artery calcium can turn into coronary artery calcification. This is typically measured via gated chest CT scans, but incidental coronary artery calcium may be found on chest CTs that are obtained for other reasons, such as lung cancer screenings. Notably, there's not a lot of data about how to score or assess coronary artery calcium on a chest CT scan that is obtained for a different reason and you find incidental coronary artery calcium, but it may be considered a liability to not follow up on this incidental finding. Coronary artery calcium is quantified using the Agatston method, and it basically sums up the area and density of the coronary artery calcium. But most importantly, this is a significant marker for ASCVD risk and may be useful in helping to stratify patients based on their risk and ensure that they're on appropriate lipid-lowering therapy. So it may be useful to know the CAC score in the following patients. So patients who are reluctant to start statin therapy and need to understand their risk versus benefit. Patients who are concerned about reinitiating statin therapy after stopping due to adverse effects. Older patients who have low risk factors and are not sure if they would benefit. And then middle-aged adults who have a borderline ASCVD risk and some factors that increase their risk. Notably, there's also a radiology guideline that recently came out that recommends using coronary artery calcium as a screening tool in both men and women above a certain age. So they actually recommend this in a lot more people than the AHA currently does. The test does have a $99 cash price, and it can be a really good option for younger patients who can afford it if it's not cost prohibitive to see if they're at risk and what they should be on medically. So once you have a coronary artery calcium score for someone, you can also calculate their reference value. So this was created from the multi-ethnic study of atherosclerosis, or the MESA study. This provides an estimated percentile for a particular coronary artery calcium score, and this is relative to someone's age, gender, race, or ethnicity. And this can indicate if someone has a high coronary artery calcium score relative to others who have the same age, gender, and race as them. So when we're talking about CAC scores and what lipid management therapy someone should be on, a CAC score of 0 confers a lower ASCVD risk, and in most of these patients, you can consider not utilizing a statin unless they have other comorbidities or factors that would cause them to be at an increased risk. In most patients who have a CAC score of 1 to 99, initiation of a statin should be considered, especially if the patient is older than 55 years old. Patients who have a CAC score of at least 100 or are in at least the 75th percentile based on their reference value that we just discussed should be started on a statin. So more importantly, when we're looking at CAC scores, a CAC score of at least 300 is associated with a proportionately higher ASCVD risk than those who have a CAC score of greater than 100. Patients that fall into this category should be initiated on at least a high-intensity statin with a goal of achieving an LDL reduction of at least 50%. A recent article in the Journal of American College of Cardiology Advances actually suggested using an LDL goal of less than 55 rather than 70 in patients who are found to have a CAC score this high. If LDL remains elevated despite maximum intensity statins, use of adjunctive therapies such as ezetimibe, PCSK9 inhibitors, or inclisiran should be considered. Notably, some patients may have a CAC score of 1,000 or higher, which is associated with the same risk as someone who has previously had an ASCVD event or has clinical ASCVD. So for patients with a CAC score this high, you might want to be more aggressive with your add-on therapy and may consider addition of a PCSK9 first rather than ezetimibe. So now we'll move on to our patient case. So AH is a 56-year-old female with a past medical history of hyperlipidemia, arthritis, a 20-pack-year smoking history. She quit in 2022. She has a family history of coronary artery disease. She is on a high-intensity statin, and her cholesterol panel is as follows. So she has a total cholesterol of 191, triglycerides of 204, an HDL of 51, and an LDL of 105. She got a lung CT that showed an incidental finding of calcifications in her arteries. Which of the following would you recommend? A, check her apolipoprotein B and lipoprotein A. B, add on lipid-lowering therapy with a PCSK9 inhibitor. Or C, obtain a CT coronary angiography to assess her CAC score. Okay, C. So we want to get a CT to assess her CAC score, given this incidental finding that needs to be followed up on, especially since she has an increased risk for ASCVD with her history of tobacco use, her family history, and her LDL of 105. So her CAC score is found to be 388.2. Which of the following would you recommend? No changes to management because she's on a high-intensity statin already. Add-on therapy to achieve further LDL lowering, or discontinue the statin and initiate a PCSK9 inhibitor or inclisiran. Yes, B. So we want to add on therapy to achieve further LDL lowering. So while she's already on a high-intensity statin, this CAC score of greater than 300 does represent a proportionately higher risk, and she should have a goal LDL reduction of at least 50%. Given that her LDL remains above 105 or around 105 despite high-intensity statin, she would be an appropriate candidate for guideline-directed adjunct therapy, and in this case, you would probably want to go straight to a PCSK9 inhibitor due to the amount of lipid lowering that you would like. So in conclusion, ASCVD is the leading cause of morbidity and mortality globally. While many novel lipid-lowering therapies have been introduced, statins do remain the backbone of therapy. Assessing ASCVD risk is beneficial in helping to guide therapy. LDL goals differ across guidelines and should be individualized to each patient. Targeting an LDL lower than the current suggested goals may be beneficial. However, research in this area is still evolving. Utilizing CAC scores is beneficial in stratifying risk and guiding therapy for primary ASCVD prevention. CAC scores may help to determine more specific LDL goals and the need for add-on treatments. And with that, I'll take any questions.
What is the theory behind like the lower LDL if the studies look at like neurologic effects or effects? Is that something related to like very high lower LDL?
I think my understanding, at least from reading about it, was that there were some theories at one point that patients with a lower LDL were at an increased risk of either neurocognitive effects or hemorrhagic stroke. So in most of the studies that assess the safety of low LDLs, they wanted to look at these events as well.
Yeah, I don't know, like, liver and why is it not?
I think because it's a newly developed theory or newly developed medication, and there's not a lot of data yet about it for them to feel comfortable recommending it in guidelines and like giving it a specific place in therapy. I also know it can be pretty expensive, so I'm not sure how like the insurance is working with covering that yet.
Any questions? Yeah, I'll let you finish it.
Then I'll be quiet. So, back in my day, I learned all about fibrates, niacin, and so where do those fit into the pathway nowadays?
So originally I had included them in the presentation, and the reason that we decided to take them out was because now their primary place of therapy is typically in patients who cannot tolerate a statin. But even in patients who can't tolerate a statin now, with all of the additional lipid lowering therapies that are coming out, they're not typically used unless someone can't afford one of the newer medications.
I was.
Let's kind of line up my holistic world, like address some inflammation and how you might manage that. That's an issue with cardiovascular disease and everything.
I mean, a lot of the lifestyle things that are recommended would be like using a low sodium diet,
Sodium got to do with
water retention.
Yeah.
Okay.
inflammation. You haven't been studying this stuff, it's an unfair question. I just wondered if you knew anything.
I'm sorry, I don't, but I can look into it and get back to you.
I have a question about relative place in therapy about bempedoic acid.
Okay.
So I don't really see this a lot on home med lists, and I assume part of that reason maybe because of its like financial accessibility. But based on your experience and like working in the care clinic this year and in your research, what is the prevalence of use of bempedoic acid, and when would you reach for bempedoic acid before you get to injectable therapies?
Personally, when I was on my AmCare rotation, I did not see a lot of bempedoic acid used. I think it's primarily recommended in the guidelines still as patients who cannot tolerate a statin. So I think in a lot of patients who can tolerate a statin, it typically goes statin and then addition of ezetimibe, and then from there, PCSK9 inhibitors. So yeah,
So its uptake has not really been very prevalent.
not that I saw, at least when I was on my AmCare rotation. I don't know if Brandy knows.
Do you want a bempedoic acid? Thank you. Any other questions? Well done, thank you so much.
Oh, yes. There you go.
Oh,
Okay.